Hello, everyone. Welcome to another BlackTree webinar. We're proud to have a great panel today to discuss the operations impact of diversifying your payer mix. So before I get started here, I'm going to have our panelists introduce themselves, starting with Mr. Bob Lebeau.
Well, good afternoon, everybody. Bob Lebeau here. I'm coming to you from Tampa, Florida today. I've been in the home health space since 1992. Earlier on, a few years ago, I had the privilege of working with the National Association for Home Care and the National Medicaid Task Force on working with providers and Medicaid MCO payers on helping to facilitate proactive communication in the early phases of the transition from fee-for-service Medicaid to Medicaid MCO rollout. And we'll be talking about that continued evolution today. But I'm actively involved as an investor in home health through my role with Together Healthcare Management, and then I'm the managing director of Oakmark Advisors, which is a merger and acquisition advisory firm based here in Tampa, Florida, focused on home health care and healthcare staffing. So thank you, Nick.
Thank you. Brad?
Great. I'm Brad Caldwell. I'm the Chief Revenue Officer of Compliant Health, one of the founders of our Credentialing product. Been in the home care and hospice space for almost 25 years, believe it or not. Started off in the telehealth arena and then moved into the software space. Sat on multiple boards, Florida HCAF board, NAC Technology board, and really here to do the best for the industry. I think we all win if we take care of our patients. And one of the mottos we lead our business by every day.
Thanks, Brad. Scott?
Scott Brashears, Vice President of Product Development and Support at Compliant Health. Have been on the provider side as an operator. And in the software side for a little over 20 years combined on the home healthcare side. And prior to that, most worked with CMS on the Part B billing and fraud abuse.
Great. Thanks, Scott. And last but not least, Brian Harris.
Hey, everyone. My name is Brian Harris. I'm one of the consulting directors at BlackTree Healthcare Consulting here with Nick. Been in the home health and hospice space for around 10 years now, working with providers on optimizing revenue cycle processes, working through cash flow issues, and a lot of other items that impact providers on the operational side. Over the past year, I've really been diving into Medicare Advantage expansion and other items that we're going to be talking through today to help providers understand what details are behind that and really prepare and work through that growth. So excited to be with this group today.
Great. Thanks, Brian. And for those of you who don't know, I'm Nick Seabrook, one of the managing principals and partners here at BlackTree as well. So a couple housekeeping items before we get into the content here. Throughout the session, we're going to have some polls coming up. You'll see them. You basically will be pop up on your screen, and you'll see the polls pop up. We encourage you to please participate in that. You know, the more participation we get, the more we'll have a better sense of the audience and also be able to respond to some of the questions that come through. From a question standpoint, you can also post any questions that you may have either in the Q&A section over on that menu or in the chat section. And we have some time saved for the end to be able to get to the Q&A. So please encourage folks to ask questions throughout here. So with that being said, we'll get into the actual details here. You can see we have a very diverse mix of folks on the panel, and that was intentional. And we're definitely starting to see, as we see an expansion into some of the Medicare Advantage. As Brian had mentioned before, he's been having a lot of focus on Medicare Advantage expansion. Right now, 36% of all Medicare enrollees are involved in our Medicare Advantage enrollees, which is, and just looking at growth year over year from 19 to 20 was an increase of about 9.5%. Managed Medicaid has also played a huge role. You know, it's no longer dealing with just one Medicaid payer. Now there's 290 managed Medicaid plans as of 2018 now throughout the country. And we're even starting to see more of the Medicare Advantage expansion. We know there's a demonstration with VBID in the hospice arena. So we're starting to see more and more expansion amongst the different payers. And we're even starting to see some different payers get into the home care world. The other reason why we wanted to bring this panel together is, you know, we're starting to see more diversification with agencies as they're looking to expand in different provider types. You know, if they're a home health or just a hospice looking to expand into potentially some of that personal care space, some of the private duty world. So as agencies are trying to get more market share, if they think they're tapped out in one market or another, we've definitely seen a trend with agencies starting to expand out more. So we thought it would be good to have a panel that represented, Bob representing both the provider world and also the M&A advisor world. Having Brad and Scott on here to more speak to the technology considerations as we talk about payer expansion, and then Brian from a consulting side. We think it's a nice, well-rounded group to be able to speak to a lot of those different avenues. So before we actually get into the questions, again, we're going to start with our polls. And again, this is going to be more to get a sense for what our audience is. So we're going to have our first poll come up here of really what best describes your agency. Are you a skilled home care agency? Are you a non-skilled home care agency, a hospice provider, or do you have multiple service lines? So that's going to be our first poll that pops up here, again, to get a better sense of what the audience is before we get into the actual Q&A. As we let our pollsters answer those questions, my first question is going to be to you, Bob. As your, what are some of your considerations that you have as you evaluate expanding to additional payers?
Mm-hmm. I think it's a good question. And I think for the group, now that we're, knock on wood, coming out on the better side of COVID and getting back to a state of relative normalcy, we've seen just in the last 60 days, a lot of provider agencies that we work with have incredible opportunities for contracting initiatives, whether it's with a Medicaid MCO, whether it is an unskilled provider having access to some of the first Medicare Advantage rollouts, or providers that are already active in Medicaid, looking at opportunities afforded by choice waivers, PACE, and some other initiatives. So the time, I think, has never been more appropriate for folks to contemplate payer diversification. The main reason why you would consider doing it really is risk abatement, as I call it, right? As you've seen folks that may have a single payer concentration, you may be at the whim of an individual state, an individual federal payer, and the change that can bring. Obviously, we're dealing with sequestration issues right now that hopefully we'll be able to abate. But obviously, just the more diverse your payer mix is, the additional ability you have to have a fully engaged workforce. And I know it wasn't really on our agenda today to talk about recruitment and retention of caregivers, but for any provider on the phone, that is probably their number one daily challenge. And it isn't often that providers think, well, if I could diversify my payer mix, could I better engage with my workforce by offering them more guaranteed hours, potentially cases that are closer to where they live, the ability to have a higher margin that may allow us to pay more competitively in your service area. So when we all struggle with retention and engagement, payer diversification can directly improve the odds of that happening, of being that employer of choice and offering job assignments that your competitors cannot have access to. Secondly, it's about getting ahead of the curve. We look at the evolution from fee-for-service to managed Medicaid. That evolution starts by having an open network. And very quickly, for example, in Texas and in Florida, after 12 months of initial rollout, it became up to the payers to decide how their network looked and if they had enough providers. So I think the more proactive you are today, coming out of the COVID pandemic, you'll be ahead of competitors that may be prolonging how quickly they're looking to diversify, and that's going to improve your chances of becoming in network while that access exists. Now, secondly, it's offering continuity of care, not only to your patients ultimately, but equally importantly to your referral sources, whether you have a physician practice or a hospital case manager that has been trying to refer different types of payers to you and you've had to decline those. Obviously, it's going to enhance your relationship with your referral sources if you can have a deeper breadth of payer relationships. Obviously, this boils down to our ultimate goal of financial gain. And we'll be talking today that can't happen at the risk of margin degradation. And we'll be talking about some tips and tactics that you're looking at the payer relationships of how you can enhance your value proposition and hopefully not only have increased market share and top line revenue growth, but equivalent margin improvement, which is important. And the last point I would add is that for those of you that may be looking at bringing on minority investment capital, we're simply looking to enhance your current banking financial relationship. Payer diversification ranks top of the list of how investors look at supplying needed capital to growing home health businesses.
Great, thanks. Some great points in there, Bob. Just for means of looking at that first poll, we have about 2/3 of our audience has multiple service lines. So I think it's something that most of our audience is probably already experiencing with some of that payment diversification. Switching gears over to you, Brian, I wanted to talk more about some of the considerations as it impacts your revenue cycle, your operations. What are some of the considerations or tips or feedback that you would give some of our listeners regarding that?
Yeah, absolutely. And I think love the phrase that Bob used there of getting out ahead of the curve. I think that's going to be a trend we see throughout a lot of the recommendations we make throughout this. But obviously, as you bring on new payers, there's going to be different rules, different ways that they operate, and your team is going to have to get used to that. That could mean one thing if you're an existing home health agency that's taking on new payers in the region versus if you're someone participating in the VBID model or if you're on the non-skilled home care side that's looking to contract with Medicare Advantage for the first time. It's really understanding those payers' rules and how they operate. And really wanted to break that down to 3 different functions. First one being insurance. This is going to be a theme throughout as well, but different payers have different portal capabilities. So you really need to take a look at it and see, okay, by bringing on this payer, am I now adding significantly more phone calls? Where if you have a Medicare or a Medicaid, you can go on the portal, look up insurance, do eligibility checks pretty quickly. There may be some payers who you need to call to figure out about copays, or their portal doesn't have strong capabilities, and in order to confirm what plan they're in or authorization rules, you need to make a call. So that could add additional complication and some additional work there. Also, just understanding what's under that payer's umbrella. We know there's certain, especially some of the larger players, where they could be under one large umbrella, but you have 7 or 8 plans underneath that have slight variances in the policy number, and they have different rules and timely filings around that. So making sure your team understands those different plans, how to identify those, and that the rules are set up in your system to adhere to those appropriately. On the authorization standpoint, tied in pretty closely with insurance verification as well, same concept. Does the payer have a portal that you can go on and do things pretty easily, upload things through there, or are there more phone calls needed? Do you need to fax? Is there hard copy documentation that's needed within there? You obviously want to maximize the portal utilization, but some payers don't offer that at this point. So you'll need to build workflows around that. And then just the differences around the payer's authorization rules. How much will they give you at the start of care? For what time frame? How quickly can you, or how early can you request subsequent authorization, and what's the process of doing that? Making sure your team understands that so you can set up different touch points and follow-up efforts in order to keep on top of those and make sure you're not missing out on the authorizations, because that can lead to denials. Again, if you're looking at going from some of the governmental payers, the traditional Medicare, traditional Medicaid, to these managed cares, you may be dealing with authorization for the first time where that wasn't a denial risk if you missed out on the authorization with the Medicare and the Medicaid, and now is with the managed care and could impact cash flow and ultimately the line. So you want to make sure those processes are strong. A lot of times we see more issues with subsequent authorization, where providers are strong at the start of care, but then there's not strong process that. You want to make sure, again, that you understand those time frames. How early in the game can you start requesting that? And then also making sure there's strong communication with clinical teams. You're going to need to understand if you're coming up on an expiring authorization, do I need to request another auth? On the home health side, it's going to be restarting. Is the visit frequency staying the same, or do we need to request something different? Collaboration and communication is always key across clinical operations in the revenue cycle. When you're dealing with authorization, it adds another layer there, because any miscommunication could lead to missed auth and ultimately denials on the billing. And then we mentioned billing a few times. Obviously, that's the catcher's mitt. Everything leads to that, but you do typically see a higher denial rate in some of these managed care plans. So working through those, you could be submitting clean claims and seeing processing denials that you need to work through. And each payer is going to have their own nuances, their own codes that you need to bill, sometimes varying between the UB04 and the 1500 on the claim format, or just different nuances on top of different timely filings. You may have some payers that you only have 90 days to bill or send an appeal, and then, or other payers that you have up to a year sometimes. So making sure you understand that and the rules and the regulations behind those are key, and something that should start early in the process if you're looking to engage and build a relationship with other payers. Summing all of that up, we always recommend building a payer. Too often we see that the payer intelligence is there with a provider, but it lives in someone's head. And if they're on vacation, it's difficult to understand what we need to do from an authorization standpoint, from a billing standpoint. Document all of this. Build a payer matrix with payer name, timely filings, appeal rights, authorization rules, portal capabilities, basically everything you would need to understand that payer and their operations. And that should help you succeed with any of the difficulties or challenges that come with the operations for those payers.
Great, thanks. Yeah, I think that's one of the big indicators there in terms of as you're trying to evaluate where there might be additional resource needs within operations would be just looking at that payer mix in general. So that leads us to our second poll of what best describes your payer mix. You know, we looked at, you know, either over 90% non-Medicare, 51 to 90% non-Medicare, 26 to 50, or less than 25%. So again, I think that really is going to contribute to what those staffing levels need to look upstream, to Brian's point, within those different revenue cycle areas. Now, we talked about operations, and one of the other considerations is looking at technology. And I think that's one of the big pieces that as agencies are looking to expand into different service areas, or if they're looking to expand their different payer mixes, you really need to consider what the impact is on technology. Do you have the technology support that you need? So I'll have this question pointed towards Scott and Brad here. What are some of the considerations and impact on your diverse payer mix on technology?
So a lot of it is really going to depend on where you diversify to. Are you diversifying more to traumatic brain injury, still visit-based? Are you diversifying to maybe pediatrics, for example, high touch hourly skilled care, or are you divesting to home and community-based care? And the reason I mention that is because they are all different. They have all different requirements. So from a compliance side, sticking on the skilled care, a lot of your auths and your orders are not going to be for 60 days. You might get a 6-month order, or you might get a year order. Depending on the state, especially with a lot of your pediatrics and TBI programs, you have to have the order signed before you can even go for the auth. So what Brian was talking about, needing to know when you're restarting a patient, I might have waited till day 55, 56 to restart a Medicare HMO patient or a managed care patient. Now, if I'm doing it in Medicaid, I have to have a full signed order, and I have to get that process started probably in day 30 if I'm on a 60-day cycle, or day 60 if I'm on a 90. So you do have to have a system that enables you to have different compliance checking as far as when the cert period is for each one. Some other things around that side also would be in your fee-for-service claims, and you get into the Medicaid. Medicaid does require a signed order in some states, similar to like you did on a PDGM/PPS claim. But remember, those were only billed once a period, or PPS you billed twice. But under PDGM now, you're really billing once a period. Well, when you get into a period in a lot of the states on the med waivers and some of those type programs, you're billing weekly, and it might take you 30 or 40 or 50 days to get that actual signed order. You don't want to let one of those claims slip out. So you have to make sure that you have a system that can hold those claims and tell you why they're held, to make sure they don't go. If you actually bill those incorrectly, even though it was purely by mistake, and you get an audit, depending on the state, and they take 10 of your claims and they find 2 of them are wrong, they're going to want 20% of your payment back. So compliance gets, I know everybody's always been afraid that, oh, Medicare compliance is horrible, they'll come and shut me down. This could be even worse. They'll come in and take your money back, and then you'll be stuck trying to fight out from under that. Some states require Hobbins for all your services that you're paying under Medicaid, even though they might have never been paid under Medicare. If you don't have that documentation, you have to put it on the claims, you have to have a copy of it. So you need a system that can help you track all that stuff. So those are some of the higher on the skilled side. The unskilled gets very interesting because you have the concept of care plan adherence. When you say that in the Medicare world, everybody says, oh, I have an order to go 6 times, I have to go 6 times. When you start getting into the unskilled care, you have somebody overseeing that care, either the state, a caseworker for the state, one of your LPNs or RNs. They're going to write up a care plan. So every time that caregiver goes and sees them for a personal care aid or companion visit, depending on which state you're in, you want to be able to make sure that the system tells you, hey, they didn't do two of these tasks in the care plan, or the patient refused them. And hey, this is the fourth time this month the patient's refused a bath. So you're looking at a whole different model where the person out doing the care, unlike a clinician in most worlds, is unable to make real decisions. So you have to have somebody in the back office that can easily identify that stuff through trending to see exactly where that kind of information is happening to you. Again, some states also require around that model. If you looked at it in the old days, up to about 2 years ago with the EVV Cures Act coming around, all this was done on paper. You left a piece of paper in the house, got signed once a week. Patient said, yeah, they were here every day from 7 to 3. They did exactly what I wanted. I haven't fallen. I haven't done any of that. Now, as you get to the EVV model, which Brad will talk a little bit later, you're having to get some states those visits signed every day. So you have to make sure that you're getting all those questions. So you want to make sure you have a system that requires that, not just for the skilled nursing side, but for your home health aides / PCAs, depending on which state you're on. And then just some of the signature requirements. In Ohio, for example, you can have a signature or voice recording. Some states you don't need anything. It just depends on each state, so you have to look around for that from the compliance. Brian probably touched best on it in the eligibility. It's also very important that you have a system that can do those eligibility checks different times for different payers. Depending on the state you're in for a managed Medicare or Medicaid contract, they can change their Medicaid provider overnight. They don't really have to notify anybody. So you might have an auth from Molina, you're going along all happy, and you find out on day 13 of your admission, the patient switched to Superior. So if you're not able to do those eligibility checks timely and just get notified of the ones that have an issue, when you typically find out is you build your second and third claim, you might have a net 30-day with some of your MCOs. It's 40 days into that billing period that you realize you've been billing the wrong provider. So now you have to go back and try and fight for an auth. So the eligibility becomes probably even more important than the authorization. Authorization obviously is ultimately important, but you need to make sure that the auth you have from the payer is actually the payer that is providing or covering that service on that given day. Claims go to a much broader subject. Brian mentioned the payer matrix. That is important. When you get into some of the more advanced programs in Ohio's, for example, in Colorado's, you have to do things like tiered rates, sliding scale rates, different modifiers. Wisconsin makes you build different modifiers during different times of the day. Overhead rates in Indiana, I know where Bob you are. If you miss out on that, nobody's going to come and yell at you. You just left $30 every time you showed up to see the patient, or at least the first time every day, sitting on the table. So the more of that can be automated through a claim system, the better you're going to be. If you're counting it on somebody to remember all that, and you're doing a large volume, especially in home and community-based care, where you are going to be doing a larger volume to be profitable, there's all kinds of chances that you're going to miss some stuff on that. So those are some of the bigger areas, but you basically want to make sure whatever you see operationally that you're changing, after you've decided which programs you're going to diversify into, that your system supports that. And it's not a one-size-fits-all. When you start getting to hourly services, for example, in billing, if I send someone in the morning and someone in the afternoon, I can't always be able to just bill 2 lines. I might have to roll them together with a summary of units. So we want to make sure all that stuff actually happens for you automatically, so no one's spending time reviewing them. As you grow your volume of claims, if you're going to have somebody sit and review each claim, you're actually going to be spending more and more money, so you're not actually making additional margin by taking on the higher volume.
Brad?
Yeah, and then just to elaborate a little bit on that, one of the things you have to be very careful on as you're diversifying is really looking at the state regulations and state by state. So some states may require different licensure to get into a different business line. The other one, if you look at some of the EVV requirements, they could have 2-3 different aggregators. The state may offer a free aggregator or the ability to utilize that free for one payer, but the old term is free, really free. How are you going to manage payroll? All the efficiencies that you should be getting from an operational standpoint when you're not integrated into your current EMR, it goes away. So you really want to look at that overall part. One thing I want to emphasize today that I tell everybody in the industry, leverage your vendors, leverage your state association, leverage your national associations, leverage your consultants. If you look at this group here, we're dealing with EVV mandates and the aggregators nationally. We're dealing and we live with this. We understand the requirements that are going to come there. We understand the pitfalls you're going to have. We understand where the efficiencies can be and then where the revenue leakage can be as well. But most people don't leverage their current vendor. With the time of diversity, there's part of that poll, there are people that are just getting ready to diversify. Can your overall platform and or partner in this business handle the businesses that you're in today, but more importantly, where you're going to be tomorrow as you start to diversify that? And that's something that can't overemphasize enough to really look at. And again, utilize the industry, utilize your relationships with your vendors and consulting to make sure you're looking at the proper partners in that space.
Yeah, the license agencies are living and breathing that EVV mandate now, and that's soon to come for the certified world in 2023. So it's going to become that much more important. Great insight there. Appreciate that to both of you. I think one area that I would say worries agencies as I look at diversifying payer mix and getting into some of these non-Medicare contracts is, to your point, I think, Bob, before, is the rates that I'm getting are just not going to be substantial, and it's going to create margin corrosion. With that in mind, you talked about before contract management and how you negotiate contracts. Any tips for the audience on really, as you're trying to evaluate those payers and getting to the table with them on how to negotiate those contracts?
Sure. Yeah, sure, Nick. Prior to our call, when I learned about this, I guess 2 weeks ago, I sent an email out to 5 different payers that we have some relationship capital with, and asked them for just their words of wisdom to share with the provider audience. And a couple of them, one of them said this in particular: please remind the group that long-term services and supports are a new area for us, and it's important to help health plans understand the breadth of services that a provider can offer both to the patient and to the health plan. And then I asked them, what were the 5 things that a provider agency should be talking about to prove a value proposition as part of joining a network or getting a contract? And there was a lot of alignment around really these 5 areas. Number 1, like we just talked about, what's the full range of services that a provider can offer? Secondly, what assurances can the provider give the payer that the right people with the right training are going to show up at the right time? Sounds pretty straightforward, right? What are the quality metrics that agency tracks on their employees and their outcomes? How reliable does the provider view themselves, and how can that be measured? And about pricing, what flexibility does the provider have of initial pricing versus post-performance contract pricing? So we'll talk about that a little bit. I think there is a misnomer that providers don't have a sales opportunity to gain access to a provider network. So there's 2 considerations. Number 1, first and foremost, you have to get a seat at the table. So you need to understand the credentialing requirements of that payer. And even as we sit here today in 2021, there is, I call it, a 1980s mentality still with many payers of, for example, requiring Medicare certification in their boilerplate contracting requirements. It takes a little bit of education with the payer to have them understand, in lieu of Medicare certification, we maintain third-party accreditation. Or even if we don't have third-party accreditation, we're meeting a Medicare certification quality of care standpoint because the state requires that as part of their audit requirements for Medicaid participation. So don't be intimidated out of the gate if it looks like the initial credentialing requirements may preclude your agency from participation. 9 times out of 10, it's simply an educational opportunity for you and the payer. On that note, we look at 3 spheres of influence in negotiating a payer contract. Number 1, you have the network rep. That's the individual who's solely responsible for network development. In the middle, you have what I call the case managers. Those are folks from that payer that are working mainly in acute hospitals, looking at high-risk, high-dollar patients, and working with that hospital utilization review case management with the absolute capacity not only to steer patients towards certain providers, but to absolutely support your involvement in getting access to the plan in the first place. So whether you have a clinical liaison, whether you have a community liaison or a business development person that is working acute hospital accounts, please, please, please make sure they're forcing themselves to develop relationships with those insurance case managers, okay? Very crucial element. And last is your field rep. A lot of folks don't deal with a field rep until they've already been contracted, and maybe the first call to a field rep is when they've got a payment issue. They had a denial, they're trying to work it, or they had an audit notice and they need help from the field rep. Well, the field rep can absolutely influence the network rep in terms of your agency having a seat at the table and getting contracted with a plan. So think of those three segments and making sure that you're hitting them from three different levels. You have your traditional sales relationship development model, but you also have a clinical operations component, and you have a billing and reimbursement revenue cycle management position. So you have multiple relationship capacities within your agency, okay? So your goal is to negotiate what is negotiable. Now, out of the gate, you may not have the initial capacity to alter your payment methodology, but you will learn that opportunity over time. And we have seen that some very positive developments in payment methodology for the what we call more in-demand sectors. And that would include private duty nursing, pediatric home health care in general, even the Veterans Administration, right? That is obviously looking at a lack of access to care to our veterans. We've seen positive reimbursement trending in choice waivers. We've seen incredible out-of-the-gate opportunities with Medicare Advantage plans who understand the value proposition of unskilled care delivery and eliminating more expensive skilled services. So the environment is rich with opportunity for those agencies that believe in relationship capital and don't simply agree on a boilerplate contract. It's important that you engage with folks. If it's not in person because of COVID restrictions, then a webinar like this is a great way to build a relationship, albeit virtually, with those individuals that can influence your initial contract and set a pathway to talk about quality measures that could lead to reimbursement changes down the road. And then just a couple other statistics to throw out is 2/3 of all Medicaid beneficiaries today are being serviced by a Medicaid MCO. So for the handful of folks that are still living in a fee-for-service world, that is about to change. I believe 23 states have fully rolled out a complete reversion from fee-for-service to allowing MCOs to control the entire Medicaid population. There are 17 states that rollout will be initiated in the next 12 to 18 months. And a handful of states that will remain fee-for-service are more rural, and I don't know how many of those folks we have on the call today, okay? The benefit in some states, though, the migration from fee-for-service to Medicaid MCO is counterintuitive. It has led to an improvement in DSOs, for example. Folks that went through this evolution in Pennsylvania saw their DSOs cut in half after the migration to the 4 or 5 different Medicaid MCOs that are handling that population. So very positive things, I think, can come out of your contracting initiatives. We talk a little bit, and we'll talk later in our call about how do we measure that. And the 5 folks that I talked to most recently in preparation for this call were very simple things. What's your credentialing of your field staff? How do you assure that credentialing is continued along their multi-year employment history with you? And how do you measure open shifts? That's becoming a crucial hallmark of quality. You work hard to get 40 hours authorized, and you're only delivering 30 hours of care. So that 10 hours of missed care is not only a gross profit opportunity for your agency, but it's also directly viewed as a lowered risk of controllable hospitalizations, right, through adverse events from that payer. And as the majority, if not all of the MCO payer contracts today are capitation models where the risk is on the payer, they very much care about missed shifts and keeping that patient with adequate support in the home to avoid emergency room visits, and ultimately hospitalization. So those are just a couple of the hallmarks that I think folks should consider, Nick, when they're looking at the payer contracting process.
Great insight there. Thanks, Bob. Brian, switching back to you, I know we talked about the operations impact on the revenue cycle, but what are some considerations, again, as we're looking at agencies who may be diversifying from a staffing level standpoint? Talk a little bit about those areas that you discussed before on how you evaluate that.
Absolutely. And it ties into a lot of the concepts that we've been talking throughout the first half of the webinar here. A lot of it is the learning curve initially too, when you're bringing on some of these new payers or even expanding into these non-Medicare payer groups for the first time. Ultimately, you can get to a point where the process is streamlined, but the staff still need to understand that, really understand the authorization process, go through some of the trials and tribulations of learning some payer intelligence for the first time. That can take a little while. And also just the other regulations around the industry. I know Scott was mentioning EVB as a big one. Really adapting to those, and we know there's been a lot going on in the last couple of years especially, but that can take some time and lead to some slightly inflated staffing levels for a little while. Looking at the three different functions that we talked about a little bit earlier, on the insurance verification side and the authorization side, a lot of it comes back to those portal capabilities. You're able to go in the portal and move through those pretty quickly rather than having to make phone calls. You're going to be able to move through more today, have a higher level of productivity, ultimately get staffing. Scott also made a great point about the re-verification. We look a lot at the start of care, but we really recommend at a minimum monthly. And to Scott's point, in some states, you might do it multiple times a month of re-verifying that insurance to see if there are any changes and then adapt and request new authorization if necessary there. The question there is, how manual is that process for your organization? Are you leveraging technology to be able to automate that? So instead of having to go through 500, 1,000, 2,000 patients every time you need to do this, you're only working through the 30 to 40 that indicates there may have been a payer change and focusing in on them. Allow your team to focus on the normal day-to-day outside of that. On the authorization side, it's pretty straightforward too. The more payers requiring authorization, the more resources you're going to need to keep on top of that and proactively follow up on the expired authorization. It's really looking at those payer requirements, how much can they give you up front, really maximizing that in place on top of that. But then also looking at collaboration between authorization and so you really want to make sure that you're getting the supporting documentation when you do get authorization to say, payer X authorized 10 visits at the start of care. Here's the authorization number and the date to approve that, to make sure that if billing does get some denials regarding authorization, they have access to go pull that and appeal those denials. We've seen a lot of providers that have really manual scanning processes when they could automate it a bit further, or they're receiving the authorization approvals electronically and then printing it out and storing it somewhere hard copy. Maximize electronic capabilities there, but make sure that information is available to the auth team and the billing team to use in any appeal scenario. On the billing side, we talked about some of the complications there, but we see a higher denial of non-Medicare payers. And as you expand and work with some of these new payers, again, you're going to go through that learning curve, figuring out what are they requiring, what are their standard denials, how do we appeal or remove that. If you're looking just at productivity of a collector that's sitting there doing nothing but following up on claims day in and day out, we typically say that you should be able to work through at a minimum 50 claims per day on Medicaid. When you look at the non-Medicare with those managed care and commercial, our productivity level for that drops to 30, primarily because those are a little bit more complicated a lot of times. You see a higher volume of denials, sometimes being complex. There's a little bit more research that needs to be done. Oftentimes more phone calls are required, and we talked about how phone calls are longer than the portal. Really just looking at those payers, especially if you don't have strong capabilities for follow-up, you're not going to be able to move through as much of the AR each day as you would with a traditional Medicare or Medicaid. If you look at a positive side, though, a lot of times with these payers, you have more payer project capabilities. You have the relationship during constant communication. I know that a little bit, but if you have the representatives there and you can work with them, say, hey, I've got 100 claims that are impacted by this issue. Rather than me sending you 100 individual appeals or correct claims, can we send this over on a spreadsheet, work through the issue as a whole? They're going to be more willing to work with you a lot of times than traditional Medicare, the Max, or the state Medicaid. So you want to look at those opportunities too as an option to really group up like issues and not spend as much time working through those while hopefully still getting. On the cash posting standpoint too, talking a lot about electronic capabilities, maximize those electronic remittances. Again, when you look at the managed care and commercial side, not all of these payers offer ERAs. I think year in and year out, we're seeing more and more payers adapt to that. But if a payer offers it, you want to make sure you're getting those electronic remittances in, automating that cash posting as much as possible. That will save your team a ton of time posting cash and allow you to refocus that on some of the denials management that we talked about. So all in all, a few different areas impacting staffing, but the key is to get out ahead of that, understand where that could be, and have strong processes in place that are communicated and understood by the team to help minimize any additional staffing needs that come across when you're expanding these payer mixes.
Great insight there. Appreciate that, Brian. So based on those last three topics we had, I'll put on our last poll here of what concerns you the most regarding diversifying your payer mix. Is it more the operations impact and staffing levels? Is it more the payer contracting side and maybe the rates you're getting? Or is it more the technology, the capabilities that the technology can support all your needs? Regarding next topic here, as we talk about expanding different service lines, Bob, from your standpoint, what are some of the considerations as you evaluate expanding out into other service lines and broadening what your offerings are?
Sure. Well, I'll talk about kind of what we've seen work well for certain agencies, and I think what also some of the growth sectors are within the space broadly. So we'll talk about what I call more traditional tangential lines, and that would be your evolution from perhaps a traditional intermittent driven skilled model to doing infusion nursing, to consideration of doing hourly private duty nursing to both adult and pediatric clients. Those both have favorable reimbursement trends associated with them. There has been a resurgence of growth in pediatric therapy, where as little as 18 months ago, we saw price compression in most states. There is now price expansion and a need for more providers as the migration to the managed care organizations has I think, seen the need to expand networks for pediatric PT, OT, and speech therapy. On the unskilled home and community-based services side, there's a world of opportunity for traditional home health providers in the world of IDD, intellectual and developmental disabilities, that at first blush you may think does not have a direct correlation to home health. But as you actually look at some of the service array, it is substantially similar to what you may already be providing under your Medicaid waiver for home health services. It may just be simply a new contract extension to get to providing those same home health waiver services to the IDD population at oftentimes improved margin opportunities. In the world of long-term services and supports, we'll see a lot of provider agencies that, for example, may only be providing attendant care services under waiver. They don't know that you can provide case management services, homemaker, respite, structured family caregiving. So our biggest advice to folks on the phone, even in a state where you may be evolving from fee-for-service to managed Medicaid waiver is oftentimes not being migrated like state plan Medicaid. So get a copy of your state's Medicaid billing guide for home and community-based services. It's usually out there on your state's website. It's usually sometimes a couple of 100 pages long. But in that document are going to be a lot of program requirements, participation requirements, reimbursement requirements, licensure requirements, and you're going to be pleasantly surprised of how many opportunities you have to expand service lines within your existing framework. So again, can't underestimate those opportunities. There's big trends nationally. You read about them every day of consumer-directed care. That's continuing to accelerate. So there are opportunities for structured family caregiving, for licensed home health agencies to be supporting that consumer-directed care model by being that intermediary between the family caregiver and the state or the payer. You already offer payroll services, so you're simply onboarding a whole new additional set of caregivers that you're not employing directly. It's a 1099 model. You're simply processing payroll and having some involvement with quality standards. So, there's opportunities right in front of everybody on the call, I think, to look at diversifying their service lines in a fairly easy lift within payer contracts they may already have access to.
Great. Good insight there. I'll switch back to Scott here, and kind of to piggyback off what you just said, Bob, and what we talked about before is there's definitely some states that are more complex or complicated than other states regarding some of the Medicaid setup, some of the waiver programs. Scott, you're living and breathing it every day, having to be the brains behind the architecture of an EMR and making sure that they're meeting those requirements. Any that stick out to you that are more complicated than others?
Usually from a good side or a bad side, depending on how you look at it, the more complicated ones have a better reimbursement rate. I mean, Ohio is a complex state from a billing side, but it also has one of the better reimbursements, which is why you see all those providers in there. Depending on the program, you might send the same caregiver into the house for 4 hours, bill one program with a completely separate billing requirement than the other one. They get into that whole type of a loaded first hour. They want to make sure you stay there long enough. The short visit days are long gone. So that's probably one of the more complex. Then you get into the county waivers, and you get into the area on aging. Every one of those has a different billing requirement, and you might have it in your service area, 4 different populations that you're trying to bill through one. That's one. Florida has got a little more complex this year just because of the integration of multiple EVV vendors. So while you have somebody out doing a service in the morning, and that's a payer covered by HHA, like a Sunshine, and you have a straight Medicaid, not that there's a ton of straight Medicaid in Florida, but assume you do, that goes to one TELUS portal. Your other payer might go to another TELUS portal. So it puts a little bit of burden on you from a back end side, quite frankly, and from a staffing that Brian was talking about. Because now when you're trying to clear what would be called an EVV exception, you have to clear it one way because it's TELUS, a different way because it's HHA. So when you get into states, Pennsylvania, while is a good state from a reimbursement, they've kind of kept it structured. So half of the state's HHA, half the state's SANDATA and the general rule. So it's a little easier to diversify. But those are some of the things you want to look at, especially is how many different EVV vendors are there. You get up in New York, for example, you can send to eMedNey. If you're in the city, you got to use a VO. Depending on who some of your payers are, you might have to send to CareBridge. And if you're in some of the other long-term care programs, you have to send to HHA Exchange. So that's where the complexity comes in, is really typically the more programs they're going to offer. But those are probably for the bigger states. Texas doesn't have as much complexity. The hardest part there is staffing, because the reimbursement rates aren't great. And you're all fighting for the same caregivers in that model. So you really want to look at the number, to Bob's point, the number of programs in the state are definitely going to increase the complexity. And that's not just the state programs. You have to look at the county or regional centers when you get into California. So you might be providing 20 hours of care a day, but a couple hours go to straight Medicaid. There's an additional waiver. There's a regional center. There could even be a county program, or it could be billing in the school board if you're doing something along the line of pediatric care. Pediatric does seem to be a more complex in a lot of states, just because you are taking the child out of the house as they age out, and you're sitting in different billing venues potentially on some of those.
Great, thanks. And then Bob, putting on your M&A advisor hat, and what Scott just outlined with some of the state complexities, how does that factor in? That and some of the service diversity, payer mix diversity, how does that impact to you, evaluate how you evaluate a potential acquisition or the valuation of that acquisition?
Yeah, I think, everyone, whether it's a strategic investor or a private equity group, is going to build an investment thesis around a potential integration. Some of those investment theses look for how well is that provider diversified, and what effect is that diversification having on margins, DSOs, bad debt reserve, bad debt write-off experience. What's the post-payment audit environment been looking like for that provider, which comes up readily during due diligence? What are the supervisory visit requirements? What's the authorization duration? What does the state budget look like right now post-pandemic? Obviously, a lot of those budget shortfalls have been closed in by the latest relief bill, so I think a little bit of the pressure is off. But what we've seen is that each investor may have a different or waning appetite for diversification. Others say, we at this time, we want a provider that is executing at the top of their game, even within a narrow payer framework. They have learned how to work authorizations to get the maximum amount of hours for clients. Because they have focus, they are able to reduce the amount of work or overtime. They're able to reduce the negative effects of a DSO trend. So I think everybody looks at it differently. You know, most of the folks that we look at are comfortable as we sit here today acquiring a business that may not yet have payer diversification, but they're likely willing to pay a premium for a platform-sized organization that has proven their ability to operationalize varied payer contracts, because that gives them confidence in the management and operations team of their ongoing ability to integrate other tuck-in acquisitions post-closing and to better operationalize the business in general. So, you know, there continues to be, I think, incredible appetite of investment in this space. COVID has only accelerated the value proposition of home and community-based services. And the trend that we have seen is the involvement during due diligence of third-party groups to evaluate the regulatory framework and they payer contracts. There is a tremendous time given of evaluating and reading every page of a payer contract for all the things that we're talking about today. So it's important on the front end, before you get involved in a process, if you're looking at bringing on investment capital, to make sure that you're executing contracts that you can deliver on and that aren't going to end up coming under contest, you know, during an M&A evaluation period. So again, I think the opportunity is incredible for everyone on the phone as you're not looking, obviously many folks aren't looking to divest, but you may be looking to your bank, right, of increasing your lending limits. And banks today are very savvy in the opportunities afforded by managed care contracting. So I think it's very relevant.
Great. Makes a lot of sense. Going back to technology, Brad, this one's for you. What other technologies do you see as an integral piece to really successful, diverse operations?
Yep. No, great question, Nick. Am I getting feedback? Sorry.
You can hear. You're not like one.
Okay. So part of it is to look at your current platform. As I mentioned before, can it handle the payers that you're doing today and the ones in the future? That is an important part of it. Even if it is in there, are you maximizing it the way the systems were designed? One thing to look at, as all the regulatory changes and things have changed in your organization, it's always time to look to redeploy, retrain, re-streamline, change your process. There's some other technologies out there. I'd be careful going out into islands. You know, it's all about integration. It's all being able to pull that into your post-acute ecosystem. So do you have the opportunity to do things like open shift notification so you can have your unskilled caregivers or caregivers in the field accept the shift? Can you get more productivity to your organization for the others? So you're increasing productivity, you're reducing turnover, you're reducing your onboarding costs. And to me, it's all about that caregiver engagement. The more we can entice, improve the quality, and keep that caregiver engaged with our organization, no matter what business line we're in, the better we'll be. As technology moves fast, early adopters, to me, it's important how you deliver the technology. Perfect example, we have customers that introduced EVV a year before the mandates in their state were mandated. So what they were able to do is show the caregivers, this is to make you a better caregiver. This is to help to make sure we're maximizing the hours we should, get our maximized reimbursement and not leave hours on the table. It's not because it's a mandate being driven down by the state. And we've seen our utilization of organizations that have deployed that properly almost double others that say, oh, this is just the state mandated part of the Cures Act that we have to do. So I'd really focus on the deployment, being that cheerleader of technology. And then at the end of the day, what does the technology do for the caregiver? And ultimately, we're all here for the patient and the reason we're all in this space together.
Great. Yeah, great points there, Brad. Appreciate that. Bob, I'm going to have you bring us home. Reminder that if you have any questions, please ask them in the chat room. I'm going to throw a crystal ball question to you, Bob. Just seeing how much payers specifically have really started to put a focus on our industry. You know, what do you see as the impact that's going to end up eventually having on overall operations and kind of really the landscape of home care in general going forward?
I think it's significant. I mean, I would draw on a couple of things that have recently happened that 6 months ago I would have told you I would have never foreseen. Here in Florida, the state of Florida saw the need to increase staffing levels in private duty nursing and actually modified the capitation risk contracting structures with all of the MCOs to create add-on payments that were based on filled hours within private duty nursing. So for the first time, the state saw that there was a need to enhance agency reimbursement. And they're putting pressure on the MCOs to do that through incentive-based reimbursement. And what's the result? You've seen positive trending in PDN contracting. Despite the big players having control of the market, they're now looking at enhancing reimbursement to allow a greater fill rate. And for those of you who are competing with acute hospitals and COVID vaccination clinics and travel nursing companies that are offering nurses higher rates of pay than ever before, that's crucially important. So I think it's a very positive development. On the unskilled side, we have seen a payer look at EVV-related task code documentation to support provider enhancement payments based on the provision of hands-on care delivery versus homemaker companion care. Another benefit of not necessarily looking at EVV just as a mandate for time in, time out, but actually driving accountability of your caregiver of delivering the appropriate care, right, to reduce potential hospitalizations. And another mechanism of communicating with the agency at the earliest sign, right? Your home health aide is oftentimes the only outside perspective of a change in patient condition, and alerting the skilled team in your office to that early is providing enhanced reimbursement opportunities from a payer perspective. So I just think the writing is on the wall that use of technology and the use of an enhanced reimbursement methodology to drive accountability is going to continue. So it's right there in front of us, Nick.
Great. Thanks, Bob. I did have a question that just came in, a Q&A. I guess this one's directed to you, Bob. It's from an M&A perspective. Do you look for higher levels of interoperability?
Well, of course, right? That would be the end all goal. But I do not see it if I'm looking from the Oakmark perspective. Interoperability has not been driving multiple valuations. Okay, what has been driving has been general diversity of the payer and DSO trending and margin analysis. The mistake that many providers have made as part of their contracting initiative is to accept the kind of statutory reimbursement and a year in not going back and attempting to renegotiate on your behalf with data that supports quality of care. So I think to become a platform and to command a higher multiple of EBITDA transactionally, it's about your ability to execute in those other areas. But obviously interoperability is a plus for a more sophisticated platform player in terms of sharing of clinical data, but I don't see it, frankly, driving transactional value at this point in time.
Great. Appreciate that. Well, I guess we're up against the hour, so I wanted to thank everyone on the panel for joining me today. A lot of thoughtful and very insightful discussion here, so appreciate all of your time, and then also appreciate all the listeners who listened in on this webinar as well. So without further ado, thanks very much, and let's go Villanova Wildcats.
Thank you, Nick.
Thanks, everyone. Thanks, Nick.
Everybody.
Take care.